Good morning and greetings from Switzerland. Today's webinar is about AVM, which is the ventilation mode of bellavista. And we're talking about the basics, the algorithms, and some ventilation strategies today. So the objectives for today are that you understand the principle of AVM after this webinar, that the difference between adaptive target and optimum target ventilation is understood as well. Then how to change settings during the course of ventilation. Learn how to wean patients with AVM, and also learn about some limitations of AVM as well. So first off, we start with the basics. If we're talking about adaptive ventilation, this can be administered in several ways. And the first level of adaptive ventilation is something we are working with on a daily basis and with each and every single ventilation mode, and that's just PEEP. Because PEEP is a setting which should be consistent. But for example, when you're ventilating a patient, the respiratory activity when the patient is breathing spontaneously is changing constantly. But you want to have a constant PEEP, so the PEEP needs to manage the base flow and the expiratory valve to keep the set PEEP maintained, or the CPAP, whatever the patient is doing. And this is already constant adaptation of one control. So the first level of adaptive ventilation, and even if you're not a big fan of adaptive ventilation, is already something like we would call PEEP. The second level is PRVC, pressure regulated volume controlled ventilation, and this is available under the name of target vent on bellavista. You have the patient, you have the ventilator, patient is ventilating, you are setting a tidal volume you want to have administered to the patient, but now the patient's lung mechanics is changing. So the ventilator keeps the tidal volume stable by changing and adjusting the inspiratory pressure. And this is also on a constant basis. So if the patient is turned to the side or turned to back to supine again, the inspiratory pressure will adapt to keep the tidal volume stable. But tidal volume, respiratory rate, and everything else is managed and adjusted manually by the caregiver. But this is at the second level. And the third level, and this is what we are talking about, and sorry, this is what we now call adaptive target ventilation. And there is a reason for that, because we have an adaptive target. Target is the tidal volume, but to achieve is in an adaptive way by changing the inspiratory pressure on a constant basis. The third level of adaptive ventilation would be AVM, because the main and big difference here is that the caregiver just adjusts the minute volume, not the tidal volume, not the rate anymore, just saying to the ventilator, please adjust or achieve 6 liter, 7 liter, or even higher minute volume for this patient. Patient requires that minute volume, the lung mechanics are changing and the breathing activity is changing, and AVM keeps the minute volume stable by adapting the inspiratory pressure, the respiratory rate, and also the I to E ratio. So we're not adjusting this ourselves anymore. This is done by the ventilator. The one thing we have to observe and watch out for and also compare with the CO2 level of the patient is the minute volume. And in comparison to the second level, this is not adaptive target anymore. This is optimum target ventilation, because the ventilator is always looking for optimum to achieve the set minute volume. And this means that AVM is kind of a universal mode, because if you look at conventional ventilating, most often start with some mandatory ventilation. switch at some point and starts to breathe spontaneously to an intermittent mode like SIMV. And now the patient has the ability to breathe spontaneously. And if he's stable enough, you would do another switch to a pressure support mode, for example. And if the patient is stable enough there and there's 100% of spontaneation, you might consider to try this breathing trial. And if this is successful, you switch or you do an extubation for the patient. In comparison with AVM, we just have AVM and patient is able to breathe spontaneously. If he's not stable enough, he will be ventilated automatically, mandatory again, and always with the highest goal to have a stable minute volume. And at some point you decide to do a spontaneous breathing trial and then do the extubation. So you really are saving some manipulation and also switching back and forth from ventilation modes. So this helps you to save manipulations on the ventilator and also switching the patient to different or from different modes to another. Looking at the parameters that are mainly responsible for the CO2 regulations, these are the inspiratory pressure. This is the rate, and there is also tidal volume when you're on a volume controlled or on an adaptive target mode. So that means these are the parameters for minute volume, and minute volume defines CO2. And looking at I2E, FiO2 or PEEP, these are responsible for oxygenation, and this is managed in the same way as in any other mode. So the oxygenation part has to do in a way that you're used to. You set the FiO2, you set the PEEP, and so the oxygenation is managed in a very usual way. But now these three parameters are managed by AVM automatically. The only thing you have to take care of is the minute volume. The way AVM is calculating the minute volume is per ideal body weight. Why ideal body weight and not the real body weight? Because the lung is not growing with the weight of the patient. So if you're overweight, then you don't have necessarily bigger lungs or bigger airways. They keep the same. So you might have to change your minute volume to cope the CO2 elimination, but the nominal volume always starts with the ideal body weight. And you can also see that this table is showing you that on adult patients, it is 100 milliliter per minute per kilogram. And this curve is increasing the lower the weight of the patient gets for pediatric patients, because AVM is also working for pediatric patients. So what is determining? It's determining the minute volume, and it's also determining the dead space. Why dead space? We'll come to that in a minute. So let's just calculate quick. A male patient with 1.65 meters has an ideal body weight of 61 kilograms. We know from the graph that it's calculating with 100 milliliter per minute per kilogram. So that means the minute volume is 6.1 liter. So it's quite easy to understand. If you go with a patient who has 70 kilo ideal body weight, it would be 7 liters per minute. If there is a patient with 53 kilogram ideal body weight, it would be 5.3 liters. And it's also here determining the dead space, which is in this case 134 ml. And I will come to that in a few slides. So now we have determined for this very patient the minute volume, and we're talking about 6.1 liters. So going here, you see that this could be achieving 6.1 liters, 5 breaths with 1200 milliliters, which doesn't sound very reasonably. This is 400 ml with a respiratory rate of 15 sounds better, but also may not be perfect. Or you could just administer 6.1 liters by giving 200 ml and 30 breaths per minute. So the truth must be somewhere on this graph, but not necessarily at the extremes. So, and this is target comes in place. And now we're talking about the Otis equation. Otis is a biologist who wrote some publications in the early 50s of the last century. It was mainly about how mammals breathe. He was not designing ventilators. He was not designing ventilation modes. He just wanted to find out how mammals breathe and what do we do to achieve breathing. And he also found out that we're breathing very efficiently. So we're not wasting much energy as long as we are healthy. When we are sick, the energy expenditure is rising and increasing, but he was looking for healthy patients. And he found out that there is always, for each and every human or mammal, an optimum rate for ventilation. And this is what the Otis equation in this AVM ventilation mode is doing as well. So Otis equation is looking at the resistance and compliance of the patient, and it's calculating a certain rate. So in this case, when you look at the graph, it's about 12. And we have now determined also the 6.1 liter per minute. And this automatically leads to a tidal volume of nearly exactly 500 ml. So that means we just get the one rate, optimum rate from the equation. And since we have determined the minute volume, we automatically get the tidal volume as well. So the Otis is doing the rate. And the tidal volume comes from the minute volume. And this is now done breath by breath, 24 hours a day, 7 days a week. So it doesn't get tired. It's just calculating constantly. And if the patient is improving, if the patient is worsening, if the patient is turned to the side, if the patient is turned back to supine, it constantly calculates and recalculates for the optimum target, and consecutively also for the optimum tidal volume, always in relation to the minute volume set. So we can conclude that AVM is a pressure-controlled ventilation mode with an optimum target minute volume control. The optimum target is coming from the Otis equation, and this is always saying that the optimum is looking for the least work of breathing. This is the rate you get, and you have always the guarantee that the least work of breathing is coming with this rate. This leads to the benefits that we have a continuous adaptation of the ventilation process. So as long as the patient is ventilated with AVM, you can always be sure and ensured that this is ventilating with the least pressure possible to give the patient the least work of breathing. And this results very often in a faster weaning. And of course, there is less interaction required because the ventilator is mainly taking care of the ventilation process. It also controls the ventilation and the timing. So there are measures in place that no auto PEEP can develop, and also no breath stacking. And last but not least, AVM allows spontaneous breathing at any time. So if the patient wants to breathe spontaneously, he can do this whenever he feels to, and as soon as the patient is awake, he can start just breathing spontaneously without waiting that someone switches over to spontaneous. He can just do it. So it's a very convenient mode. But we have now determined the optimal rate. We have now the optimal target and tidal volume. And there need to be some more measure to keep this when type of ventilation even more safe. And these are the lung protective rules. So first one is that this is the one rule which is set by the user, and this is talking about trauma. So this can be any type of trauma, and this is set by the pressure limitation. So in this case, the pressure limitation or the P limit is 40 millibars. It can be lower. You can set wherever you feel that you have to set it. There are operating procedures which say 28 would be the upper limit, 30, 32. You can just set it where you need to have it. And that tells AVM, okay, this is my space where I can go. So in this case, I can increase the pressure up to 40 millibars. This includes the PEEP. So it's the absolute pressure, not the relative pressure. And this is the only protection rule you can apply yourself. And if you set an unreasonable high pressure limit, AVM potentially will use it if the situation makes this necessary. The second one, and now where the dead space comes into play, which we determined right at the beginning with the ideal body weight. And you might remember that this was 134 milliliters for this 6.1 liter patient or 61 kilo patient. So that means AVM just protects the ventilation or the patient by just taking the dead space times 2. This would be around 270 milliliters, and this marks the minimum tidal volume. And the minimum tidal volume would be always 270 ml. So whatever happens, the inspiratory pressure will be increasing or the pressure support will be increasing to keep the patient above 270 ml. So dead space ventilation is not possible. On the timing base, we prevent auto-PEEP by determining the expiratory time constant. That means that the expiratory time constant is your limiter and telling the ventilator how much time the patient needs to exhale. And this is the time AVM will give the patient. So it's not possible to develop and build up auto-PEEP. And this is also constantly changing on the lung condition of the patient. So it's not a fixed value, which tells you, okay, the respiratory rate can't go beyond 25. It's always moving. It's always changing with the condition of the patient. And last but not least, there's also apnea. So if the patient is not breathing spontaneously very much, or he's sighing, as soon as the rate is going at 5 breaths per minute or even below, mandatory ventilation will come back and keep the patient ventilated. So this is always something which is automated. So there's already apnea backup mode within the adaptive ventilation mode as well. When you look at that shape, it also tells you, currently it's a square shape. So that means the lung condition of the patient allows high volumes, as you can see on the y-axis, and it would also allow quite high respiratory rates, as you can see on the x-axis. So that means that this seems to be a fairly lung healthy patient, but you can also determine or see the lung condition, the actual lung condition, by just looking at that protection window. And for example, if you have an obstructive patient, it's rectangular shaped, and you also see that the maximum respiratory rate in this case would only be, I would say, 12 to 13 breaths per minute. So that means the expiratory time constant is very long, and so AVM wouldn't allow to ventilate this patient beyond that border, because then it would build up autopeep. And that means these patients are struggling with their airway resistance. And so AVM is giving them the maximum, or giving also the user an indication of the maximum respiratory rate. And if you see a protection frame shaped like this, you already know by entering the bedside this patient has an obstructive problem. We can't say exactly what the problem is, but you know by looking at that protection frame there must be an obstructive problem. Going in this way, we also see that this is more horizontal rectangular shaped. So this means that this patient doesn't have any problems with exhaling, but the maximum tidal volume is very low. So that means this is more looking, we are looking at a restrictive patient, and the restrictive patient is kind of pneumonia ARDS patient. So he doesn't have any problems with exhaling, but you see, looking at that shape, that this patient has a very low compliance, and that means that his tidal volume is very low to achieve the set minute volume. So now we are ventilating our patient with AVM. Everything looks good and fine. We're doing our blood gas, and now we see the patient is still high CO2, and we want to change that. Usually now we would have to decide to increase the inspiratory pressure, to increase the tidal volume, or the rate, or both. But how do you do this on AVM? Because we don't have those buttons anymore. We have just the minute volume button. So what do? If we have to increase the minute volume or decrease the minute volume ventilation? We just have the 6.1 liter. And now we need, for example, 20% more. And this is just what we're doing. We're just telling the system, okay, I need more minute volume, and I adjust 20% higher than before, which results in 7.4 liters now. And now AVM is just recalculating. And maybe the tidal volume will go up a bit. Maybe the tidal volume will keep the same and the respiratory rate will increase. It really depends. And this is what the system is doing now. So it does the work for you, and it recalculates for you what would be the best for the patient to keep the optimum target, and also to keep the patient at the new minute volume you want to have. And so in summary, talking about the working principle, AVM, you start with setting the patient height to calculate the ideal body weight, then start the ventilation. There are initially 3 breaths to measure out the lung condition of the patient and the respiratory mechanics. After that, it will adjust, and you adjust the minute volume for the CO2 regulation. You can also use the ETCO2 measurement of the patients to do this. Adjust PEEP and FiO2 for oxygenation as you would do in any other mode. There are the lung protective rules we were talking about to prevent trauma, to prevent autopeep, to prevent dead space ventilation and apnea. And of course, the patient is allowed to breathe spontaneously all the time. And just to show you how this works, I will switch to the ventilator and have a short demo. You see now the ventilator here, and I will just start the ventilation. I will change this to the AVM minute volume graph. And what we see now are the first 3 breaths to measure out. And now you see the frame, you see that blue ball, and you see that white sphere. The white sphere is the calculated optimum. And now AVM is putting the blue ball in that direction. And also the white sphere and the white point of the line is telling you that this would be 7 liters per minute to ventilate. You can also see that the pressure is also adjusting. But we can also say that the pressure seems to be fine, but the respiratory rate is not there where it should be. Now it's adjusting the pressure as well. And now the blue ball, which is always symbolizing the patient, has now reached the area of the goal. And if we look at the minute volume, he overachieved a bit, but this is now in an area where it's readjusting to get back to the 7 liters. If we need to change this, for example, that we have to increase the minute volume, we go 10% higher, and now it would be 7.7 liters. And now if you look at the graph, something will change. It's deciding to increase the respiratory rate by 1 breath. And so we have achieved 7.7 liters. And if we go even higher to 20% increase, it now decided to go 1 respiratory rate higher per minute to achieve those 8.3 liters. This is how AVM is doing it now. And if we go back to maybe 90%, it will recalculate. And now you see that the tidal volume and also the respiratory rate is changing again. And it will also decrease, as you will see on the peak pressure monitoring value, the inspiratory pressure as well. Maybe we go a bit lower here, just prove that it's really changing. And now the peak pressure has changed as well. Okay, so we go back to the presentation. I will stop the ventilation. We will come back for a second demo in a few minutes as well. Okay, talking about spontaneous breathing. Spontaneous breathing, as we already said, is possible at any time. And the patient starts to breathe spontaneously, and we have set minute volume. It can happen that the patient is breathing above or beyond that set minute volume. So this is something you have to have in mind when the patient is breathing much higher tidal minute volume as adjusted. You also have to think about that the minute volume you adjusted is what you thought would be sufficient for the patient, but when the patient is breathing spontaneously, he is doing what he's comfortable with. So if the actual tidal volume, the actual minute volume, sorry, is beyond what you said, you maybe should consider to support the patient by also increasing the minute volume even when the patient is breathing 100% spontaneously. Because what AVM is doing is that when the patient is breathing spontaneously, you set 7 liters, for example, the patient is breathing 9 liters, and you think, yeah, that's fine for the patient, but AVM thinks, no, my user told me I have to achieve 7 liters and not going beyond that. So what AVM is doing now is decreasing the pressure support. And this is, when you're in a weaning process, this might be a good idea by just weaning the patient or maybe even training the patient a bit, but this shouldn't be overdone. So if the actual minute volume coming from the patient is much higher than what you said, you should support the patient and increase the minute volume as well. When the patient is not doing anything, the strategy might be different because then you have to somehow stimulate and activate the patient to do some breathing himself, but not when the patient is already doing much more than you have said. This is quite important because otherwise it could happen that the patient could get exhausted. Are there contraindications? Are there things you can't ventilate with AVM? Generally spoken, any lung condition like COPD patient, to just name the extremes, or an ARDS patient can be ventilated with AVM. There are 3 things to consider. There is leakage, because when there is leakage, the expiratory time constant is not easy to determine. And when the expiratory time constant is not determined, the AVM mode is struggling because it relies very much on the expiratory time constant. So if there is lots of leakage or there is leakage coming from a drainage, there may be other ventilation modes which are better in this situation. And it can't also be used for NIV because in NIV we expect leakage. If there are hiccups or pathologic breathing patterns like Cheyne-Stokes, and you see it on that trending data, AVM is also struggling to calculate and recalculate because of that always recurring breathing pattern. So you see that the rate and also the minute volume doesn't look very constant. So this might also be something where you have to consider to change or switch to another mode. And of course, neonates, there is no current mode for neonates existing. So neonates below 5 kilograms shouldn't be ventilated with AVM as well. So, but these are the only limitations I know of. I have experienced many times that ARDS patients and also COPD patients are really well ventilated with AVM. But of course, you know, you have to know your limitations, and you maybe sometimes have to reconsider your goals like in any other ventilation mode. Now talking about ventilation with AVM and how to ventilate. And there are many good reasons for using AVM, mainly because of less interaction, stress and workload for the caregivers. And there are lots of studies which show that, and especially in these times we are now in here in early 2020, that there is a high risk for user errors and other things which might put the patient at risk by doing settings all the time. And maybe when there is work overload, there are happening errors, that's for sure. And also when you have to ventilate patients longer than necessary, and this can add up in a high cost. And so finding a ventilation mode which is steering the ventilation into a direction might be a beneficial thought to it. Going back to the settings we have, just for repeating. So we look at the ventilation mode like PCS-IMV. We have the rate, we have the inspiration time, we have the PEEP for the oxygenation, and comparing this many controls and buttons with AVM, We have now just one button left for the ventilation. We don't have a timing button anymore. This is gone. And we have just one button for oxygenation besides the FiO2 button, which is not listed here. So we have also already spared some buttons. And looking now at the ventilation and going to weaning, we stop the sedation for the patient, for example, and the patient is not breathing spontaneously. And that's the only reason where you might consider to decrease the settings to a lower value than the 100% where we're starting with. Usually in most of ventilations, you're increasing over time. And at some point, the patient starts to breathe with 100% minute volume, and this is fine. So you can just take your weaning with these values, but there may be a situation where the patient is awake and he's responding to your questions, and he's showing you that he's also really awake, but he's not breathing. This can happen. So what you can do as a strategy, reduce the percentage of minute volume to increase, in this case, the CO2 for the patient, so that the patient is forced to start spontaneously breathing. I wouldn't go below 70% of minute volume, just to keep a minimum minute volume for the patient if the patient maybe has other problems than just not breathing spontaneously. And so I would just keep a minimum minute volume to keep the patient in a good state. And if you want to do a spontaneous breathing trial after the patient is really breathing constantly and stable, you can also do the spontaneous breathing trial on AVM by just putting the minute volume to 25%. So then also the support is at the very minimum, and the patient has really to breathe spontaneously on its own. But of course, like on any other spontaneous breathing trial, the patient must be closely monitored. If the patient fails the spontaneous breathing trial, you have to take measures against it. And the minute volume settings, they don't necessarily correlate with the spontaneous activity. So if there is 120% and the patient is breathing spontaneously and is on a good way to be extubated or for a spontaneous breathing trial, there is no need to reduce the percentage of minute volume settings. So if the patient is breathing spontaneously well with 100%, that's fine too. So you don't have to set or switch to a certain value to keep the patient on the course for weaning. As I said already, there is the difference between actual breathing and the patient moves away from the target. I would always say the target rate, if the target rate is 15 and the patient is breathing more than 10 breaths per minute above the target rate, you should look for a reason. Why is the patient breathing that way? Is he still comfortable? Does he have problems, pain, anxiety? Are there neurological problems? And if you want to help this patient and support this patient, just increase the minute volume to get him more pressure support so that the respiratory rate will decrease again. But always have in mind that there must be a reason, as long as the patient is starting to get uncomfortable, that he's breathing at that high rate. So we have another demo. Okay, we start again. We already are at 80%. So we have again those 3 test breaths. Now what I want to show you is, and also with the animated lung, just change from pressure to the animated lung. And now you see the diaphragm. So you see that the patient is breathing spontaneously. And also that the peak pressure now is coming down. So we are now already in the course for weaning. And now I'm moving away from the breath rate. So I would just simulate. So what I can do now to improve the situation for the patient is to just increase my minute volume to give him more support so that the respiratory rate will come down a bit and maybe just improve it a little bit more. So now the patient would be now in an area where he's still breathing a bit higher, but he's now better supported than before. And if we have set the right setting, the inspiratory rate will decrease while the pressure support will increase. If the patient would stop breathing, it would also start faster that the mandatory breath will take place. Because if you have set 70% and the patient is breathing at 140%, it will take quite a while until the mandatory breathing will start. So as long as you're nearer to the actual breath rate of the patient, you will support the patient much better in just taking the right steps here. Okay, then we go back to There is also a clinical decision chart for AVM. These are just recommendations. So if the clinical situation looks a bit different, if the physician is deciding in a different way, that's all fine. It's just some proposals to facilitate the use of AVM. And so we just start with some questions. Does the patient have dyspnea? Or is the target rate from the patient above 10 from the calculated target rate? Is the CO2 above normal? Or is the PO1 higher than -3? Then, if you can say yes, you have to increase the minute volume. And then start again and ask the same questions in 30 minutes again. If you can say no, so the patient seems to breathe in a calm way. Is the spontaneous rate 0% or very unstable and the PaCO2 normal? If you say yes, then reduce the minute volume, go back to start and ask the same questions again. If you can say no, is the patient stable for at least 60 minutes and the spontaneous breathing is 100% and the CO2 is normal? If you can say no, back to start, back to scratch. If you can say yes, then you have to look at the oxygenation and if the PEEP is correct and below 8 or 5. If this is not the case, just go back to start again. If you can say yes, is the inspiration pressure fine as well? And if it's not the case, then no. And reduce minute volume and go back to start again. If you can say yes, then you should consider a spontaneous breathing trial. So it's quite straightforward where to go with it. And you just have to ask yourself those questions and either they're yes or no. And so it defines the course where to go. So it's just a bit of help, but there might be a situation where this decision chart does not fit, and so the decisions of the clinicians are always superseding this chart. So for the implementation of AVM, it's very important. It's beneficial, but you also have to have some things in mind. It should be a team approach. So if either the respiratory therapist, the nurses are not 100% convinced and the clinician is, it will be a bit difficult to get AVM started, and the opposite way as well. So everyone has to be in the same boat, everyone has to be aligned that this is a mode everyone wants to try and work with, because the approach and working with AVM is different than working with any other mode. I would always suggest to start with a healthy lung condition patient, just that you can learn on what AVM is doing and how AVM is changing the course of ventilation. And then get experienced when you are comfortable with AVM to ARDS, lung injury patients and COPD patients. And of course, some of the protocols of the hospital organization have to be adjusted to AVM because it's a bit different. You have much less controls than with any other mode. So also this needs to be reflected in the protocols or operating procedures. So if we summarize AVM, it's a pressure-controlled optimum target ventilation mode. And having in mind, there is an algorithm, an equation, which is defining the optimum target and the best respiratory rate for lowest work of breathing. The AVM and the AVM algorithm is intended to ventilate all patients from in to extubation so that there's no switch to another mode is necessary anymore. The percentage of the minute volume setting is responsible for your CO2. So the minute volume setting is your CO2 button. You always need the ideal body weight, and that's a given to start this kind of ventilation mode. And as already said, the optimum target is the point for least work of breathing. And there are lung protection rules that prevent unphysiologic settings: barotrauma, auto-PEEP, dead space ventilation, and apnea. So we have come to the end of this presentation. Thank you very much. If you have any questions, you can always ask your local dealers, ask Wire directly on the website, and so we will see you soon in another webinar. Thank you and goodbye.